As we know, last year nephrology has become more like a ritual that we have been used to for last few years, and it is one of the most awaited programs of the year, which everybody looks forward to. So we have made some changes this year to the program. So instead of one, we will be having 4 speakers today. Among the speakers, Dr. Anand, he will be speaking on glomerular diseases, development and glomerular diseases in last 1 year. Dr. Kapil will be speaking on topics related to transplant. Dr. Faizan will be speaking on CKD, hypertension and renal replacement therapy. And Dr. Vishal will deliberate on topics of acute kidney injury and therapeutics, the developments during last 1 year. The chairpersons for today are Dr. Nishan Deshpande, Dr. Prashant Malviya, and Dr. Prakash Ketan sir is also supposed to join in some time. So without waiting, we'll start with the proceedings. I hand over the proceedings to our chairpersons. Thank you.
Wonderful to have all of you here and seeing the huge numbers. We have been encouraged, and I can see all the preparations, and we are very eager to listen to the content. So without any ado, I'll welcome Dr. Anand Chellappan and let us have his talk.
03. Very good evening to all. So, welcome to Lords. So, I think this room is called Lords. So, it happens to be a rough terrain, but I seem to be underprepared. So, I've taken a call to use 6 of my best batsmen. So, we'll be discussing about these 6 studies which were published in the preceding year. I will not be going into a lot of them. But I've just chosen 6 out of them which possibly made an impact in the preceding year, that is 2022. So I think today I'd be more of an audience rather than a speaker. So glomerular disease is something which is very close to my heart. So I've just chosen these 6 studies. One is testing 2, other is Prednos 2, other is CART therapy, Plexin ANCA vasculitis, antinephrin antibodies, and steroids and IRGN. So let me begin with the testing study. So this is a study which span a decade, right? So that's very inspiring because I'll just share some insights of these studies so that it makes an impact to all of you. So this study has been going on since 2012, and the second part of it completed just some few months, maybe a year back. So the investigators wanted to investigate whether steroids have a beneficial role in IgA nephropathy. As we all know, IgA doesn't have a concrete treatment as of now. And many studies in the past, including Stop IgA, they did not reveal a significant benefit of immunosuppressants. So this is a beautiful infographic which was made by Dr. Amit and which was published in nephrology2023. This was the testing 1 trial. So they initially went ahead and tested full dose, that's what we call 0.81 milligram per kg steroid in IgA nephropathy, which has after completion of supportive therapy for some time. That is basically we give ACE inhibitors or ARBs, optimal supportive therapy, and they compared it with placebo. So what they found was there a significant number of adverse events. As we see, serious adverse events. So serious adverse events are events which can endanger life, increase hospitalization, and increase morbidity. So this trial had to be prematurely stopped. So because of this increased number of adverse effects that we see here, 28 versus 4 in the placebo arm, this trial had to be stopped. But then this trial was done by the George Institute, which is known for its academic trials worldwide, and they've provided path-breaking trials in the past. So the investigators still were determined to take this trial forward. So they took the learning points from the trial that giving a high-dose steroid in this disease, that is IgA, may possibly increase the infection risk. They wanted to modify that, and among the infections, they did find pneumocystis as one of the important infections in the patient cohorts. So they tweaked these 2 parts of the trial and then remodified and placed it again on floor, and then they started going ahead with the second part of it, that is testing 2, which is the low-dose testing trial. So what they did was they reduced the dose of steroids, from 0.8 to 1 milligram per kg. If we say of prednisolone, they reduced it to almost 0.5 milligram per kg body weight. This is after optimal therapy with ACE inhibitors or ARBs. Again, this is an infographic by one of my colleagues in NSMC from Africa. So this just shows us that 503 participants were there. So the initial testing had a predominantly Chinese cohort. Almost more than 3/4 of them were Chinese. So it was more of a biased kind of a cohort. But then when they did the second part of testing, a good number of centers were also enrolled from other Asian countries, almost 6 from India. So one of it was SGPGI, MMC and other centers were also involved in this. I think ITDS was also involved. So this part of testing too had a sizable population which was also non-Chinese. So that's one which was also an improvement over testing 1. So what did they find here? Even in testing 1 or testing 2, use of steroids is definitely associated with improvement in the composite outcome. So they were concerned with the composite outcome of composite is where we club few outcomes. So 40% decline in GFR, kidney failure, or death due to ESRD. So when we compare this between the placebo arm and the oral methylprednisolone arm, now don't ask me why they chose oral methylprednisolone. Pfizer was the sponsor of this trial, so they chose to give oral methylprednisolone. But then the centers had the privilege to use whatever they want. So some of the centers did use prednisolone that we commonly use. Right? The dose is slightly different, not much. So they found that the outcome of composite outcome was definitely better in patients who received steroids. Now this was a 6-month duration, so we don't know what happens after 6 months. So there was a proteinuria reduction, there was a preservation of GFR, and the slide just shows that the hazard ratio is 0.53, and the adverse events still were a little higher, but then definitely much lesser than the high dose cohort. So you can get away with the side effects of steroids and at the same time achieve a balance in the GFR and the proteinuria. But then a long-term follow-up again did not show much of an improvement in the proteinuria at 3 years. So we still do not know whether it improves a long-term outcome, but definitely in the short term it does stabilize the GFR and has an improvement if you use it at a lower dose. Now there are many questions when this study came out, because this study was started in 2012 and later was remodified because of the investigators. They continued to pursue it despite a negative, being a negative study to begin with. So that's something which is very, very commendable, and this is possibly the largest study in IgA nephropathy. That's again another hallmark thing, and it's very surprising to see that unlike in cardiology or other specialties where we have patient numbers in thousands, 4,000s in RCTs, even the most commonest glomerular disease has the largest RCT still has only 500 patients. So that's possibly something to do with recruitment and the penetration of research that has gone to the nephrology community, possibly that has to improve. So they did find a benefit of steroids. But then does it stand good in this SGLT2 era? That's something that we need to think, because nowadays SGLT2 is also coming into the picture when we manage IgA nephropathy patients. So this was in an era when SGLT2 was not there. So they used it on a background of ACE and ARBs, and 80% of them were on optimal therapy. So whether this is applicable to the current generation, again, it's not something that we will have to see. So that's about the testing trial. So now coming to the next situation that we commonly face is, I am sure we are all adult nephrologists, but fortunate or unfortunate, we do treat a lot of pediatric patients. So in India at least, maybe that's the picture may change over time because the pediatric societies are also coming up and they're doing a good management of these patients. So there's been a contrasting evidence when it comes to how do you manage patients when somebody has a respiratory tract infection, and what do you do about steroids? So do you use them daily, or you use them at what dose? So the PREDNOS-2 trial was on the basis of these inconsistencies in evidence which were there. So they went ahead and did a multicentric study. So this study, again, the merits of it is it's a good number, a sizable number compared to the previous studies that have been done in children with nephrotic syndrome. So they chose children with nephrotic syndrome, a total of 122 centers, and the mean age was 7.6 years, and it was between 2013 to 20. So it's a double-blind trial. So that's again one of the plus points of this trial. And they randomized to placebo or prednisolone, which is at 15 milligram per meter square per day for 6 days. That is, these patients is given as a prophylaxis during an upper respiratory tract infection to prevent a relapse. So that's what's the dose that they used in these patients, and they checked whether there was a difference in the outcome. So as we see here, the primary outcome, the upper respiratory tract infection related relapse was the primary outcome. It was not much different between the two groups. That is, when you see the placebo group or the prednisolone group, it was not much different. Contrasting to even the KDIGO guidelines, which just say that we can give load of steroids during these daily steroids during upper respiratory tract infection. So it did not show much of a difference between the two groups. The secondary outcomes were also not much different either. So we have the various secondary outcomes, and even the cumulative dose of steroid was also not much different between the two groups. So this again gives rise to a lot of thought as to how do we go about managing these patients, considering the background of all the KDIGO guidelines. So they concluded saying that administering 6 days of daily low dose prednisolone at the time of an upper respiratory tract infection did not reduce the risk of relapse of nephrotic syndrome in children, at least in the UK. So going ahead to one of the most fascinating things which happened in 2022 was this. So it's called something called CART therapy. So we have these chimeric, it's not something which is, even before we did NFJC workup for this trial, I somehow believe that these are things which will not come down to India over a long period of time. But then a month back I had an opportunity to interact with clinical biochemists from all over India. So it seems apparently this therapy is brought down to India, and it's made available because of works of investigators in IIT Bombay along with TMH. So what is this CART therapy? So it's basically you are going to, it's a chimeric antigen, T-cell antigen. So what we do is we try to get away with some of the diseases. Predominantly this therapy came in for leukemia. So you try to destroy a clone. So to destroy a clone, you create your own robot or something like that. And here the robot is a chimeric T-cell, a T-cell which has a chimeric antigen. So we all know that T cells are restricted by their MHC, right? So CD4, CD8. So they are MHC restricted. So they restrict to the cells that they destroy. Now you're going to bypass this by using a chimeric T cell. So you do a leukapheresis, take out the WBCs from the patient, right? And you introduce a vector, usually a viral vector, and which has this gene, and so this leads on to the surface expression of a chimeric antigen, which will bind to the target antigen that we need to, right? So if it is a SLE, if it's possibly a B cell. That's what we want to destroy. So if it's a leukemic cell, then it will target the leukemic cell. So we have the privilege to decide which type of cell we will want to destroy. So this is this idea of this stemmed from the studies in leukemic patients, where they've been using it for ALL and other blood cancers to destroy these cells and induce remission in children and in studies. And it's an extremely expensive therapy. There are only 6 forms of CAR which are available, but fortunate that now it's possibly going to be available in maybe a few years in India also. Phase 2 trials are going on. So in this they studied just 5 patients with lupus nephritis and some multisystemic involvement, and they did a leukapheresis. That's what's shown here. I'll just make it very simple. So they did a leukapheresis, and there's definitely some preparation which goes before we do this kind of a stem cell transplantation type of thing only. So you have to deplete the patient's own cells with the chemotherapy, then you have to give fludarabine, cyclophosphamide, and then you have to infuse these cells which will populate the patient's body. But then there will always be a relapse of the B cell also, which we see in lupus. And when it comes to lupus, what are the role of B cells? Because most of the time we use either cyclophosphamide or MMF as induction. So the B cell therapies have never been very popular. Let's say even rituximab. Now we have at least belimumab and other drugs. But then it all depends on how long you induce B cell depletion. That's a crucial factor. That's one reason why the LUNA trial and all did not show benefit with rituximab. So these were shown to be effective in depleting these B cells, and even when they repopulated, they were more of naive B cells without the expression of the malignant phenotype. So So they showed that there was definitely an improvement in these LEDAR scores, and they used remission criteria like the Doris remission criteria, and nephritis also had remitted. All these over short term, the 3 months follow were all showing a good response. One of the main problems that we see with that they say is there with CART is the cytokine release syndrome, which was not very significant according to them in the patients that were studied. At least in comparison to leukemic patients where this form of therapy is being used, they propose that it is relatively safer when they have tried this for lupus patients. And even the long-term, the reconstitution risks were reconstitution of B cells were also satisfactory, and there's no significant relapses. So they concluded saying that in patients with treatment-resistant SLE, this form of therapy achieves drug-free remission 3 months after treatment, and was tolerated with only a mild cytokine release syndrome in patients with SLE. So this remains yet to be proven in, on a large scale. So this is possibly a small number of patients that they have tested, since it was just a phase 2 study. Now, coming to the more complex situation that we face in nephrology is always plex. So it's always perplexing or complex, whichever way you put it, fits. So we time and again keep asking this question whether this is effective or not. So the initial evidences for plex came around 1980, 1990 when investigators found out that it definitely retards the progression to end-stage kidney disease and improves long-term renal outcome. But then the MEPEX trial and the PEXIVAS trial had come. MEPEX trial had shown some benefit of the plasmapheresis, and then this was countered by the landmark paper PEXIVAS, which did not show benefit of plex, questioning the entire evidence of whether we should give plex or not, and it dichotomized the entire nephrology community, with many saying we will not plex, while some still holding on to plex. So this was a systematic review and meta-analysis, so which tried to include 9 studies, RCTs, and they tried to analyze this question again: does it help or it does not? So on a 12-month follow-up, this could be irrespective of the type of plex regimen. It could be the dose was also irrespective. So they possibly tried to keep it as pragmatic as possible. So at 12 months of follow-up, they found that there was definitely a reduced risk of end-stage kidney disease, however, at the cost of an increased infection risk. And there was also no significant effect on mortality. So we have all been taught that even if the creatinine is more than 5.6 or something, plex and all will help, and diffuse alveolar hemorrhage, it does help. But then the PEXIVAS had a different thing to say. But what after this? Again, this brings again a new confusion of whether plex has to be used in ANCA vasculitis induction or not. So they concluded saying that the current evidence does not demonstrate a strong role for plex in addition to standard care in preventing death. Plex may delay the need for dialysis, which could improve a patient's quality of life, but it has serious adverse effects. So this is like you take the therapy, but still you don't take the therapy. It's something like that. So again, it's left to the physician to decide what it is. But then prudence-wise, I would say what most of them feel is if somebody has an aggressive renal disease or a pulmonary disease, it's still better to go ahead and plex the patient. Possibly that's what I see when globally people talk about this issue. And if it's an elderly patient or somewhere where you don't expect a life expectancy which is very long, I would still not flex the patient compared to younger patient where you may still offer a longer renal life. So that's possibly the stage where we stand when it comes to flex. Now coming to the next the disease, this is possibly the best disease which any of us would want to treat, at least in the glomerulus. Can anybody guess it? Yes. So minimal chain disease. So this is a thing which question whether it is really minimal change or whether it is something else, right? So definitely minimal change is possibly most satisfying and gratifying disease to treat, at least in children. So that's a clause that I have to put, because in adults it may not always be all merry and happy all the time. So investigators found that this disease, which we have been believing that it's minimal change, doesn't have any no associated pathologies, there's no other antibody associated or nothing associated with it, was ultimately shown to have some kind of an association with an autoantibody. And we all know that the slit diaphragm is made up of all this podocin, nephrin, and stuff like that. And the congenital nephrotic syndromes, we know they are also associated with defects in these proteins, and which lead on to nephrotic syndrome. So the idea of this stemmed again from identifying some minute glomerular IgG deposits in patients with minimal change disease. So of course they have the power and they have the infrastructure to go into the glomerulus and see. So I think they ended up discovering this antigen and its corresponding antibody, which is the anti-nephrin antibody. So it's a proof of concept study. So it has changed some the way we have seen MCD. Though we all know from initial times all the humoral hypothesis that it's a T-cell mediated or a humoral disease, but then now we have some basis for it. Now they used ELISA to find out this anti-nephrin antibody, and Western blot was done on glomerular samples to isolate the antigen, and they did a conofocal microscopy. So because you have to prove that this has to cause that, you have to demonstrate that this antigen binds with that, this antibody binds with that particular antigen. And they have this large cohort, the Neptune cohort, in which they studied patients with MCD. And what they found was in patients with 18 out of 62 patients with active disease, it was positive. And as controls, they used patients who are healthy, or they used patients who are having membranous nephropathy, who are anti-PLA2R positive membranous nephropathy. So these are patients without minimal change disease. And during the 11 out of the 18 patients who had positive, they also had a subsequent relapse. And during relapse, they found the levels had gone up. And in between, during remissions, the levels were undetectable. So 14 out of 18 patients had IgG staining, and IgG and nephrin co-localization was confirmed. And there's no co-localization with synoptopondin or other antigens. So is it a non-specific trapping? They also confirmed that it's not a non-specific trapping that we see in many glomerular biopsies. So they concluded saying circulating autoantibodies targeting the podocyte protein nephrin were discovered in a subset of adult pediatric patients with MCD, and adult and pediatric patients with MCD, and the serum level was highest during the periods of active disease. So this just gives again possibly this is a initial study which will lead on to more investigation, like we have seen in membranous nephropathy. Thanks to Professor Sanjeev Sethi, we have many antigens in membranous. Maybe in the future we will have more antigens to see in minimal change disease also, and may not remain minimal for long. Concluding my glomerular series, I've just taken 6. I'm sorry I've not gone into many of studies which might have also come up in the last year. There are a lot of new drugs in the pipeline for several of these diseases. So this is one study which was the author is possibly was my senior, and we have spent innumerable times in rented rooms trying to attend interviews for exams. Many of it he cleared, many of it I cleared. Finally, he ended up in MMC, I ended up in SGPJ. So it was very proud to see this paper published, written work done by him, which was possibly one of the landmark papers which should be in IRGN, and it was done by Madras Medical College under Gopal Krishnan sir. So they studied the impact of steroids in IRGN. So they took patients, adult patients with IRGN. Again, infection-related glomerular nephritis is always a confusion whether to give steroids or not. So they took 52 patients, and these are patients who had creatinine of more than 1.5, and it was a single center, open label, parallel arm study. So they had aimed for a sample size of 80, but then they could not because of the COVID pandemic, and they ended up taking only 52 patients. And they excluded patients who had crescentic disease of more than 50% crescents and more than 40% IFTA, because these are cases where the steroids in a chronic patient it may not be of much benefit. So they excluded some of them. Those with active infections they excluded, and those in whom the infection was diagnosed more than 3 weeks back they excluded. So in these patients they tried steroids versus standard care, that is supportive therapy without steroids, which many of us do follow. So steroids they used 1 milligram per kg for after 3 pulses of 1 gram of methylprednisolone, 1 milligram per kg for a month, and then 5 milligram per week taper and stop. If somebody has a recurrent infection, then they would withdraw steroids earlier. So what they found was there was not much of a difference in the renal recovery, which they said as a GFR improvement of to less than 60 ml per minute. It it was 65.4% in the treatment arm and 53.8% in the supportive care only arm. And the adverse effects were also higher when we see in the steroid arm, that is 46.2%, and many of them were infections compared to 7.7% in the treatment arm. So this again gives some kind of an evidence, definitely not a very robust evidence because of the limited sample size, and definitely suggests a single center study. But then with diseases of this sort which are not very common, and identification is also not very easy. The identification depends upon the histopathological and the clinical criteria, which was put down by Samir Nasser. So not all centers are in a good position to diagnose these disorders very conclusively. So sample size again will always be a difficulty for diseases like this and crescentic diseases. So it does stand an evidence at least against steroids. Now some take-home points from the methodology that they used were, we all do screen for infections. So I just take the opinion of the house, like if they are thinking of IRGM, what all infections do you rule out? Because not all the time it may be active. So what all infections do you commonly rule out? If you're thinking of a proliferative GN, or most likely an IRGN or something of that sort, you'll rule out lupus and other things. You just like to take the opinion of the house. Do you have any protocols at your place? Anybody?
Yes, sir. Yeah, like what we used to do, like most of the time infection we used to get it most of the time URTI, or some of the infection we used to get it in IRGN. Like diabetic patient, they used to have this ulcer, diabetic foot, and they used to develop IRGN. So it was like we were knowing that what infection is there. But few of the patients, echo is very important, because sometimes you get endocarditis as an IRGN. So I think that is one of the point. And what other things? I think we can. Echo is very important.
Echo,
if we are not getting
a clear-cut infections also.
Infections also.
I think they have a protocol there, because every center has its own peculiarity. That's what I feel, because I've been working around many places. So I think some centers have IRGN, some centers have MG, and some centers have lupus. So they, I think, have more IRGN. So they follow this protocol of, apart from the cardiac and skin. Skin is possibly the most common infection which has been reported in this study also. They do screen for genitourinary infections, and they have screened for ENT infections, ear, nose, throat. Dental infection is also something, and skin. These three particularly, they have a protocol in the institution that they have been following for screening all patients whom they are suspecting to have some kind of a proliferative GN, and that was possibly followed in this study as well. And similar kind of infections they had found out. And some interesting things were, later two of the patients turned out to be C3 glomerulopathy also later. So again, this diagnosis of infection is always one kind of a not very clear kind of stuff. So we do get, and they were not able to isolate the bacteria in many of the infective organisms in many of the syndromes. So they concluded this study saying that this is a single central trial. So the steroids, corticosteroids, did not significantly increase the rate of complete renal recovery at 6 months, and there was a significantly increased risk of adverse events associated with the use of corticosteroids. So that's how they concluded, and possibly the times are not very great for steroids. Most of the glomerular disease, we are slowly trying to wean off steroids, but then that's the only effective vaccine we've so far had for glomerular disease. Hopefully we will have better drugs in the future to target the glomerular diseases, at least those who have an autoimmune background. Thank you for the
Very nice presentation, and not only have you gone into the trials, but you have also given a perspective about what do you think about that. It's very great. One thing I was curious whether if we talk about IgA nephropathy, I could see that they have recruited patients only those who have more than 1 gram of proteinuria.
Yes.
So are there any other attributes like the Oxford classification, whether they have accounted for that also?
So that's actually a very pertinent question. This trial started in 2012, and later it was modified in 2017. But then the Oxford MEST and the Oxford MEST-C came into the picture much later in 2018-19. So that was not a part of this study only because it was later. The understanding of the importance of pathology and importance of pathologists putting together the criteria, need for a uniform assessment worldwide so that we can compare this thing, like somebody from India and IGA and Oxford, to compare, they needed this Oxford score. That's why that was not a part of this. But having said that, now they are trying to validate this in the with the Oxford. That it's called the validation cohort, so that they are doing it. The postdoc, they are doing a validation with the Oxford scores. They are trying to do it and see whether there are differences with respect to certain categories. Like we say E1 has more response to this thing, or if M1 is along with S1, we say the response would be better to steroids. So they are looking into it. That was definitely one of the points which many of them had raised. But then the reason was it was a very long trial, much before we anticipated such things.
We will need more information.
Yes, definitely.
Any other questions about?
About IgA nephropathy, there was some paper regarding use of hydroxychloroquine in IgA nephropathy. I just want, like, have you come across? There was paper in 2018 or 2019 whether they use hydroxychloroquine in IgA nephropathy.
I have come across the paper, but then I don't know whether such findings were replicated in multiple other strong RCTs, or I'm not aware of an RCT which shows a lot of benefit with hydroxychloroquine. Because if it had been in 2018, then it should have figured in the KDIGO guidelines. It still hasn't figured, so I doubt there's robust evidence to recommend HCQS.
Thank you, sir. So one thing is like in Prednos 2, they have compared the low dose prednisolone with the placebo. And already the recommendation is to give the prednisolone when the patient is having URTI in MCD patient, like to avoid the relapse.
These were, yeah.
Again, so I don't know why placebo.
Again, this was also prior to the KDIGO guideline, which came up in 2021. So even after the KDIGO guideline, again we are still not very clear. And the KDIGO guidelines was based on few studies which were not adequately powered, had a lot of bias. So I still feel the research question was pertinent, and the patient population will also decide. This is a UK population. If we take our population, it will be totally different. Many of them will be running around with URTs. So I would say even if the guidelines had come at that point also, it will still remain a pertinent question. But then the time that they started, this was not there. The recommendation, solid recommendation was not there, though people used to say you convert it into daily prednisolone and give.
Yeah, I mean, sir, KDIGO, I don't know the exact dose. Like we generally give around 30 milligram or 40 milligram per meter square. So what do you, like how much dose?
If somebody is on alternate day steroid, what we generally do is we make it daily steroids.
Yeah.
Or at least 0.5 milligram per kg per day. We convert it into daily steroids. Usually 5-6 days, or till the URT is subsides. Unless it's very significant. What I generally do is if it's a major sepsis or infection, I don't do all this. I usually withdraw steroids and treat the infection. If it's just a minor URT, something which is just precipitating, then I would give
this
a
must
short
be the
dose.
half hour of that, like 0.25.
Yes, yes. And this, even patients who have attained remission also, they've given to prevent prophylactically relapse. So like those who are off steroids, to prevent relapse.
Nice presentation. And there was a study shown by you, Plex in unconstituted. So was it performed only in for renal indications, for the extra renal indications?
Plexi was, yes.
Yeah, and was there any creatinine cutoff or dialysis dependent or independent patients were taken?
So that's also very nice question. So Plexivas was possibly a landmark paper which had gone into depths and which gave a concrete evidence. So that they did include patients with pulmonary hemorrhage, and what we are more concerned is all those crescentic types. So which was 20 to 25% of the entire cohort. It was not a large majority of them, but they did stratify it into different groups based on the creatinine, mild, moderate, slightly higher, and very high. Like 2 to 2.5 to 5 to 6, like that. They had made 4 groups, but they did not again find a lot of difference between the pre-specified subgroups in Plexivas. And even with DAH also, they are not very of a conclusive opinion for Plex. You can correct me if I'm wrong, but that's what I feel. The percentage of crescentic disease was much lower, maybe around 20 to 30%. That again leaves us with the question of whether to give it in those who are rapidly progressive or not. But then the meta-analysis again kind of has this.
Yeah, and about that T-cell therapy,
Yes.
Was it infused peripheral, through peripheral? And how it was done?
I would not comment on it, sir. I think it was peripherally infused, but I should check and get back. They can exactly. I feel mostly it would be through a central catheter they would have administered, but I would have to check the exact methodology. How it is administered. It's usually, yeah, that's how it is done.
Because I have seen T regulatory infusion through periphery, and
I think that's
so
I'll have to
how it is done.
exactly. But it's very interesting.
Interesting,
And, yeah, it's very interesting to. I think Dr. Rahul Parwar, I think, he heads this Immuno Act, which is in IIT Bombay. So they have clubbed with Tata Memorial and they have treated leukemic patients, and the response has been extremely good. And the cost of Indian therapy comes to around 30 lakhs, and they propose that it might come down even significantly lower in the upcoming years. So maybe it will be a game changer.
T-cell therapy was the first scenario where the cytokine release syndromes were recognized. And as a
Yes, in the 80s.
people know that in this scenario it's not welcome.
It is not.
So I think we have a lot of food for thought. Thank you, Dr.
Thank you so much.
I would now welcome Dr. Kapil to have his presentation about the transplant scenario. In the past.
Good evening, everyone. I would be discussing the transplant part of last year in nephrology. So I would be basically discussing guidelines and papers both. Guidelines, there were two important guidelines last year. One is the management of obesity in kidney transplant candidates and recipients. Guidelines from recommendation from the working group of European Renal Association. And second were Indian guidelines of diagnosis and management of post-transplant infections. Expert opinion from South Asia. This was published in IJT October 2022 supplement. This being a very big guideline itself, I won't be discussing it in detail. And these are the papers that I will be discussing today. So coming to the management of obesity in transplant candidates and recipients, the recommendations by the working group of ERA. Firstly, when we evaluate the patient for transplantation, the ERA group recommends measuring waist circumference or waist hip ratio in addition to BMI in patients with ESRD living with obesity who are assessed for kidney transplantation. The main rationale for this is BMI cannot differentiate between lean body mass and fat. So in addition to BMI, they also recommend using measuring waist circumference. And also prospective studies have shown that waist circumference is directly associated with mortality in both patients who are on dialysis and who are post-transplant. And it also suggests accepting patients with a BMI of 30 to 34 for transplantation if they are otherwise considered suitable, and not to reject them just on the basis of BMI. The reason being, if they compare the outcomes of patients, obese patients who are on dialysis versus who are on transplant, the mortality and survival is better with transplant even with a BMI up to 35. It also recommends counseling patients with obesity about possible increased risk of perioperative complications such as delayed graft function, wound morbidity, acute rejection, and diabetes. And it also suggests that kidney transplantation will be optimal treatment for patients even till a BMI of 39 who are ESRD and being considered for transplantation. Now this guideline correlates with the KDIGO guideline of 2020, which also recommends to consider patients below 40 for renal transplantation. It also suggests not delaying waitlisting or transplantation solely on the basis of increased BMI in patients with BMI of till 39 and who are otherwise considered suitable for transplantation. It suggests above 40 to go for a bariatric surgery first before kidney transplantation. And patients who are with a BMI of more than 35 and at least one major obesity related condition, it also suggests undergoing periodic surgery before considering for kidney transplantation. And regarding the type of surgery, the working group recommends laparoscopic sleeve gastrectomy over other forms of surgery in kidney transplant candidates. So coming to the papers, this was the RCT, the best fluid trial. It was a randomized controlled trial of balanced crystalloid solution versus saline to prevent delayed graft function in diseased donor kidney transplantation. As we know, saline is the most commonly used intravenous fluid in transplantation, but it might increase the risk of DGF. This is mainly due to the increased chloride that is filtered, which goes and stimulates the macula densa, which leads to the tubuloglomerular feedback and afferent arterial vasoconstriction. So it is proposed that patients who receive normal saline during the transplant surgery, it might lead to precipitation of DGF, or it might also lead to the delayed recovery of DGF. So in this trial, patients who underwent disease donor transplantation were randomized 1:1 to receive IV fluid therapy with balanced crystalloid solution or saline and for up to 48 hours post-transplant until the fluids were ceased. The primary outcome was in this trial was delayed graft function, which was defined as dialysis requirement within 7 days of transplant. Secondary outcomes were post-transplant hyperkalemia and EGFR, acute rejection, graft failure, and mortality up to 52 weeks. A total of 808 participants were randomized and they received a transplant in this study. Coming to the results, the participants in the balanced crystalloid group had a lower incidence of DGF compared with the saline group. The balanced crystalloid used in this trial was plasma-like, and the effect was consistent across all the pre-specified subgroup of donor type, kidney donor profile index, machine perfusion, and ischemia time also. And the incidence of hyperkalemia was the same in both the groups. And there was no difference in the graft function at 52 weeks. There was also no difference in acute rejection, graft failure, or mortality in this study. So they also, this study was mainly Australian study. So they also tried to compare the population, whether this study population was comparable to other other patients, other ESRD patients waitlisted for transplant, and they found that both this best fluid trial recipients were comparable to the Australia and New Zealand transplant registry and also the US scientific registry of transplant recipients. So basically this transplant findings, this study findings could be applicable to other countries as well. Now next is the Admiral study. It mainly looked into clinical outcomes from assessing donor-derived cell-free DNA. It was a cohort study of 1,094 patients in 7 transplant centers who received a single kidney recipient, not a repeat transplants were excluded. And important point is 90% were disease donor, and also multi-organ transplants are excluded. And the trial was till the follow-up was at least till 3 years post-transplant. And these patients underwent a median of 6 results, that is 6 times. Median of 6 times the cell-free DNA was assessed in this population, and they analyzed the donor de novo DSAs, EGFR trajectories, allograft rejection, along with donor-derived cell-free DNA. What they found is the consistently elevated donor-derived cell-free DNA predicted a more than 25% decline in EGFR over next 3 years. Also, donor-derived cell-free DNA more than 0.5% was associated with a 3-fold increase in the risk of development of de novo DSAs. And these donor-derived cell-free DNA preceded the onset of de novo DSAs. So probably donor-derived cell-free DNA could be an early marker even before DSAs are being measured in the blood. Also, there is a significant elevation in donor-derived cell-free DNA during rejection ahead of changes in serum creatinine. So probably donor-derived cell-free DNA could be a marker, and it can be used with DSAs to predict the future EGFR of the patient and also rejection. And this study demonstrated a broad utility of donor-derived cell-free DNA as a leading indicator ahead of clinical presentation of allograft injury, formation of de novo DSAs, EGFR decline, and also subclinical rejection. So we tend to use a lot of immunosuppressive drugs in patients who have glomerular diseases, and when they turn ESRD, after they undergo transplant, they are given further immunosuppression. So what is the risk of malignancies in these kidney transplant recipients who are exposed to immunosuppression in pre-transplant for the treatment of glomerulonephritis? So this was a single center retrospective analysis. It included kidney transplant recipients from 2005 to 2008 to 2020, and out of that, in that year range, around 184 patients who had a basic disease as glomerular disease were included, and they were compared with 579 patients who did not have glomerular disease as the primary cause of ESRD. The pre-transplant immunosuppression included patients who received cyclophosphamide, rituximab, mycophenolate mofetil, and CNIs. And the outcomes were solid or hematological malignancies, non-melanoma skin cancer, and post-transplant lymphoproliferative disorder. What they found is the hazard ratio of development of malignancies post-transplant in patients who received immunosuppression pre-transplant was 1.82. However, there was no increased risk of non-melanoma skin cancer or post-transplant lymphoproliferative disorder. As far as the type of immunosuppression is concerned, the risk was highest with rituximab with a hazard ratio of 3.82. So use of pre-transplant immunosuppression, particularly cyclophosphamide and rituximab, for the treatment of glomerular diseases is associated with an increased risk of developing malignancies post-transplant. So probably these type of patients, we should be more careful and thoroughly screen them when they come for follow-up. We often tend to reject the cadaveric kidneys who have significant albuminuria. So this trial was done to see whether how these kidneys fare in the future. So it is a utilization and clinical outcomes of kidney transplants from deceased donors with albuminuria in the UK. So it examined the relationship between deceased donor albuminuria, kidney utilization, survival, and also kidney function. It was a national cohort study on adult deceased donors and kidney transplant recipients between 2016 and 2020 of UK Transplant Registry. It examined the influence of donor albuminuria, and in this trial, albuminuria was defined as more than 2%, more than 2 plus on dipstick. It also looked on kidney utilization, early graft function, graft failure, and EGFR. Around 18% patients of 18% donors in this time frame had significant albuminuria. So after adjustment of confounder, this study found that kidneys from donors with albuminuria were less likely to be accepted for transplantation. It was 74% versus 82%, and around 16% patients in this study, that is 1550, which is a significant number, came from donors with albuminuria. So in a follow-up of 2 years, out of the recipients who got the kidneys with albuminuria versus the recipients who got kidneys without albuminuria, 8% and 9% of transplant from donors with and without albuminuria failed. So there was no association between donor albuminuria and graft failure as per this trial, with a hazard ratio of 0.91. And there was also no association with delayed graft function, patient survival, or EGFR at 1 or 3 years post-transplantation. So this trial may be used, this trial might help us to increase the donor pool of disease donor transplants. So 2 years back there was increased evidence whether that if the cadaveric donor is HCV positive, whether to accept the kidneys or not. Most of the centers, including KDIGO guideline, recommended accepting the donors, but after that treating the patient recipient with direct-acting antivirals for 3 months. But this was the first trial which has actually looked into what happens with the liver of these transplant recipients. So liver outcome in renal transplant recipients who acquired hepatitis C infection from an infected graft. The study is based on liver biopsy findings. So this was a retrospective cohort study from 2018 March to 2019 October. It included 89 kidney transplant recipients who developed de novo HCV infection after they got a kidney from infected donor. And out of that, 29 patients agreed for liver biopsy at a follow-up. And this follow-up is significant. It is after 28 months. So all these patients, all these recipients achieved sustained virologic response (SVR) with directly acting antivirals. And when they did liver biopsy of this kidney transplant recipients, they found 86%, that is 25 patients had F0 fibrosis, that means no fibrosis, and only 14%, that is only 4 patients had F1 fibrosis. None of these patients had F2 to F4 fibrosis, and there was no difference in the fibrosis of patients receiving HCV treatment within 6 weeks versus after 6 weeks. So this study concluded that kidney grafts from viremic donors resulted in HCV infection in all the recipients, but there was no adverse events observed with the use of directly acting antivirals, and none of the patient had significant fibrosis at a median of 28 months after kidney transplantation. So we also have a histological evidence that these kidneys could be accepted for transplantation. So we usually perform protocol biopsies in patients who have ABMR, but we rarely do it when we have ACR, that is when we have a T-cell rejection. We hardly do protocol biopsies because the creatinine tends to come down earlier. But this study actually looked into what is the importance of follow-up protocol biopsies in patients who had TCMR and who received treatment. This was a retrospective study, and it included 146 patients. And out of this 146 patients, they found who were treated with steroid pulse alone, there was a complete histological response seen in 83% of patients with borderline rejection, 82.5 with grade 1A, 67 with grade 1B, and 50% with grade 2A. What this study concluded is when patients with complete renal response was only seen by kidney function and not by biopsy. That means the patient was assessed only on the basis of his eGFR at the end of treatment. 14% only had a partial or no response histologically, which means around 14% of patients whose eGFR came to normal, they still had some histological evidence of T-cell rejection in the kidney biopsies, and 68% had a complete response histologically. So this study mainly conclude that if we just rely on eGFR at the end of treatment with rejection, we might overtreat or undertreat the patients. So along with the histology, eGFR histology also is important in treating this patient. So coming to the last and one of the most important, that is gender disparities. This was the paper from IKDRC. It has looked into gender disparity in kidney transplantation. In living donor kidney transplantation, there are around 4,087 patients, and out of, if we see the donor pool, female donor comprise around 71% of the living donor pool in this single center. And even if we consider paired kidney exchanges, female recipients are only 20%, as against to female donors, which were 79%. And disease donor transplants also, female recipients were 32%, and males were 68%. So there is increased need to readdress social issues like financial disadvantage, education, and it is also required to increase the awareness about donation in our population. Thank you.
Similar classification is done on biopsy.
Sir, I think F0 F1 is on biopsy, sir. Fibroscan will tell only the stiffness. As far as I know, F0 F1 reading is done on biopsy only, sir.
No, they comment about F0, F1 on fibroscan.
Oh, very good.
They
But
will-
fibroscan, the grading is similar what you told on H2. I just wanted to confirm whether the biopsy grading is also done as F0, F1.
Yes, even I was wondering whether on biopsy they say F0, F1 or not.
And that study only 28% patient underwent a liver biopsy.
28 patients.
28 patients.
86 where 86 patients 86 patients received kidney from HCV positive fibrosis.
But anyway, we are taking kidneys of HCV positive donor and treating them with direct acting
Yes, sir.
antiviral.
We had evidence
And
of
there are a lot of parameters by which we can find the liver, whether the patient has got any liver illness, rather than going for biopsy. I think biopsy is the last, unless he becomes symptomatic or something like that.
this study was basically done to increase the donor pool, sir, because till now we had after SVR what happens to the liver we had no idea. So this was done after 2 years of transplant to see whether the liver are fibrosed or not, whether there is any subclinical infection in the liver.
This thing is that very good presentation. One is the BMI you told. BMI of 32, 39 should be included. I don't know whether in our practice or in Maharashtra for disease donor, do we include BMI in the parameters? I don't think so.
We do include, like, I didn't understand the question.
Like BMI should not be a criteria for exclusion of the patient for disease donor kidney
That's
transplant.
what they have told.
Yeah, they have
Only
concluded.
BMI should not be there. If along with BMI there are other factors
Yeah, more than 40 or
yeah.
something like that.
If it is more than 40, then okay. If it is less than 40 and other factors are there, then you can consider for surgery before transplantation.
What I mean is, when we list the patient for the disease donor kidney transplantation, do we include any parameters like BMI in that?
No.
I don't think so. We don't include it.
We include parameters, but then that's not an exclusion
Exclusion
criteria.
criteria.
Any of these patient will not be put off the list.
You didn't clarify about waist hip ratio. You said about BMI. And how about waist hip ratio? What any cutoff or something they have mentioned?
No, they have not mentioned any cutoff. They have just told that more than 102 in males and more than 88 in females is significant, and it should be taken in that way. Otherwise, there is no exclusion criteria for waist hip ratio also. What they mean to say is, by this guideline is, if do not define obesity just on the basis of BMI in these patients, because there is no association with long-term outcomes. But there is association with waist hip ratio and long-term outcomes in these patients. So it's better to include both while we assess the patient, both BMI and waist hip ratio to be included. So that will give a better idea whether this patient is really obese or not.
It was regarding donor.
Basically.
I think wonderful presentation, Kapil, and we have a lot of to learn from this. We can proceed with our next presenter, Dr. Faizan, about CKD and renal replacement therapy.
For the sake of availability and maybe cost also, we are using normal saline. If the blood pressure is hypertensive, then we prefer renal-active. If the hypertension is not under control, then we prefer renal-active.
I have recently joined here in Aureus Hospital.
Marcus for giving me this opportunity to present this, through which I put myself back into reading actually, which I've lost past 2 years. So I'll be discussing the few important trials which have come up in hypertension, CKD and dialysis. We all know that it is the treatment of mild and moderate hypertension in patients, pregnant patients, is uncertain, and to answer that whether treatment of mild and moderate hypertension in pregnancy will have some beneficial effects on pregnancy outcome and fetal outcomes is not known. To address this question, because there in the background there is different cutoffs given by different guidelines that American College of Obstetrics and Gynecology says that don't start treatment unless the systolic blood pressure goes beyond 160 and diastolic more than 105. And on the contrary, the other guidelines, few guidelines is better to start treatment even if the blood pressure goes above 140 or 90. So to solve this question, this CHARP trial, the editor has come with the CHARP trial. It was an open label multi-center trial done in US, which enrolled 2,408 pregnant patients with a singleton fetus and gestational age of less than 23 weeks with a diagnosis of mild chronic hypertension. Into two groups. The first group was control group, in which they let the patient with no treatment unless the blood pressure went above the 160 by 405 diastolic. And the second group was an active treatment group, in which the patients were initiated on antihypertensives even if the patient's blood pressures were less than 160 or 105, with a target goal of blood pressures less than 140 or 90. And the primary outcomes were preeclampsia with severe features, placental abrasions, fetal or neonatal deaths, or indicated preterm births less than 35 weeks. And the primary safety outcomes were birth weight less than 10th percentile for gestational age. It was found that there was a significant difference in the composite primary outcomes in the treatment group. The primary outcomes happened only in 30% patients compared with the 37% in the control groups. And also the the primary safety outcomes were similar in both the groups. They concluded that in pregnant women with mild chronic hypertension, targeting a blood pressure of less than 140 by 90 will be a better for both pregnancy outcomes and safety. It will not affect much on the fetal outcomes. So after the publication of this study, even the guidelines of obstetrics and gynecology have given a recommendation that they should lower down their thresholds of initiation of antihypertensives to 140 by 90. The second significant trial which had come in the field of hypertension was the aprocitentan drug for a resistant hypertension. We all are aware that hypertension has a significant impact on cardiovascular comorbidities, and the resistant hypertension, as the name suggests, it is very difficult to treat and accounts for almost 10% of the hypertension patients. So endothelin receptor pathways play a significant role in the pathogenesis of hypertension. However, with the current drugs, it is still unopposed with the current medications, leaving behind an area for a good opportunity for having a trial. So Professor Marcus et al. Conducted this precision trial. It was a multi-center trial conducted in North America, Europe, Asia, and Australia. It was in 3 parts. The part 1 was 4 weeks in double blind, in which the patients were randomized to placebo or aprocitentan 12.5 mg or aprocitentan 25 mg in 1:1 ratio. After completion of 4 weeks, the part 2 was 32 weeks single patient blind, in which the patients, all patients received aprocitentan 25 mg, followed by the part 3, in which they withdrew the drug to some patients, dividing them into placebo, aprocitentan in 1:1 ratio. The primary endpoints were least square mean change in the office sitting office systolic blood pressure from baseline to week 4 and from withdrawal to week 40. And it was found there was significant least mean square change in office BP was significant in the patients who received aprocitentan 12.5 or 25 compared to the placebo even at week 4, and it was sustained at week 40 after compared to the placebo group after withdrawal in the part 3. The adverse events included edema, fluid retention, which were significant in patients who received aprocitentan compared to the placebo group, 2% only. However, there was no significant adverse event which needed needed any specific therapy or withdrawal of the drug. The 11 patients died during this study, but however the study group did not attribute these deaths to the related drug. They concluded that the study showed aprocitentan was effective in lowering blood pressure at week 4 with a sustained effect at week 40 in resistant hypertension. Coming to chronic kidney disease, you all know that SGLT2 inhibitors have won our hearts, giving benefits in cardiovascular as well as renal outcomes in the previous trials. However, there was still a need of some study to know whether the effects were sustained or are there in chronic kidney disease patients with diabetes or non-diabetes, with albuminuria or without albuminuria. And also at the advent of the EMPA kidney trial, the results of the CREDENCE and the DAPA-CKD were not actually published, so the study was continued. This study randomized 6,609 patients with a follow-up of 2 years. Patients included had a GFR of as low as 20, with other patient group having a GFR of more than 45 to 90, with albumin to creatinine ratio of more than 200 milligram per gram. So the primary composite outcomes were progressive chronic kidney disease or CV deaths, or hospitalization for congestive heart failure or CV deaths, which occurred more in the placebo group compared to the empagliflozin groups. And the results were consistent in patients with and without diabetes, and as well as albuminuria and non-albuminuria groups, which concluded that empagliflozins in patients with chronic kidney disease has a beneficial effects among a wide range of proteinuria with CKD who were at risk of progression, and the empagliflozin therapy led to a lower risk of progression of CKD or deaths from cardiovascular compared to the placebo. We all know that we hesitate to continue the RAS inhibitors in our patients who are advanced CKDs or have progressed to higher stages. So there are a lot of previous studies who showed that removing the RAS inhibitors improve GFRs or give us some time to create AV fistula or buy some times to patients to get ready for transplants. However, there are a lot of beneficial effects which RAS inhibitors have, and they should be continued in these patients even if there is a continued decline in GFR. But there was no randomized controlled trial to address this question. So the stop ACE group did this study. It was an open label randomized controlled trial in 39 centers in United Kingdom, which included 411 adult patients with stage 4 or stage 5 CKD with GFR of less than 30 and having a 2 ml per minute per meter square progressive decline over 2 years. All patients had at least were on RAS inhibitor for more than 6 months before the initiation or inclusion into the study. After this, they divided these patients into 2 groups. The first group continued RAS inhibitors and the second group had discontinued RAS inhibitors. And the primary outcome was the decline in eGFR, and the secondary outcomes were reaching end-stage kidney disease or requiring renal replacement therapy. And the other outcomes were major adverse cardiovascular events. It was found that there was no significant difference among both the primary and secondary outcomes or any major adverse cardiovascular events. Hence, among patients with advanced and progressive chronic kidney disease, the discontinuation of RAS inhibitors was not associated with a significant between group difference in long-term rate of eGFR decline. Coming to our next trial, we all know that finerenone, which has come up a new molecule, a non-steroidal drug, and we have noticed the 2 big trials, Fidelio and Figaro, DKD trials, and have proven benefits of cardiovascular and kidney outcomes in patients with chronic kidney disease and diabetes. However, both the trials had different range spectrums of eGFR and albuminuria categories. To come to know the effect of finerenone over a wide range of eGFRs in chronic kidney disease and albuminuria, they come with a pre-specified exploratory analysis, which is called as Fidelity, for the finerenone use in kidney outcomes in patients with chronic kidney disease and type 2 diabetes. So it is not a trial, but it was a post hoc analysis of combining the both Fidelio and Figaro. Combining both patients, they just took a data and compared it. Overall, there were 13,000 patients in both the trials, which included stage 1 to 4 CKD and type 2 diabetes. All of the patients had optimized RAS blockades. The baseline eGFR and UACR were the patients with an eGFR of less than 60 ml per minute per meter square were 60% in, and patients with UACR more than 300 were 67%. The effect of finerenone on composite kidney outcomes by eGFR and UACR were significant in both the relative risk reduction of kidney outcome were significant, and also the reaching of ESKD was significant compared to the placebo across all the groups of albuminuria categories and eGFR categories of this. So hence, and the adverse events leading to hyperkalemia was were not that significant, causing the consideration of discontinuation, because it was very low among the patients. Among patients who had significant hyperkalemia, comparing the GFR, it was more among patients who had GFR less than 60, and in the patients who had finerenone group. Hence the finerenone improves kidney outcomes, including reducing the risk of ESKD, and is well tolerated in patients with chronic kidney disease and type 2 diabetes. So these were the 3 major significant trials in chronic kidney disease, which were practice changing. Coming to dialysis, we all know that there is always a concern about cardiovascular effects in treating the anemia in patients with chronic kidney disease or patients who are on dialysis. So there is always a need of some drug which will prove a cardiovascular safety, and that has led to the various trials concerning various molecules. One of such is roxadustat. Previously, we know that desidustat has proven the efficacy in patients who are on CKD, but their effect or the side effects in patients with dialysis is not known yet. Roxadustat versus epoetin alpha for treating anemia in patients with chronic kidney disease on dialysis is a ROCKY study. It included around 2,000 patients on dialysis for more than 2 weeks with a HP of less than 10 if the patient was were untreated with ESA, or a hemoglobin of less than 12 gram if the patients were treated with ESAs. They were randomized to roxadustat 70 to 200 milligram oral and a dose titrated to based on the hemoglobin levels in a subcutaneous epoetin alpha. And the primary outcomes were mean change from baseline in HP over 28 to 52 weeks. It was noted that there was significant increase in hemoglobin in roxadustat group, and also the proportion of patients experiencing serious adverse events were almost similar in both the groups. Hence, the roxadustat effectively increased the hemoglobin in patients with chronic kidney disease on dialysis with an adverse event profile comparable to epoetin alpha. The next trial is about cooler dialysate in patients with dialysis. We all know that despite a lot of advent in the therapies and researches, the mean duration of life of our hemodialysis patients goes around 4 to 5 years. Majority of deaths are related to cardiovascular events, and we know that the hypotension, intradialytic hypotension also plays a major role in cardiovascular deaths among our dialysis patients. So there were studies, there were small unrandomized studies published giving a good effect of cooler dialysate to avoid the intradialytic hypotension, giving some cardiovascular benefits in these patients. However, there was no randomized controlled trial before this. So they studied the cooler dialysate to see the effect to prevent cardiovascular deaths in dialysis patients. This was an open label cluster randomized superiority trial conducted in Ontario, Canada in 84 hemodialysis centers. There were around 15,000 patients randomized to cooler dialysate, which had about 35.8 degrees centigrade dialysate temperature compared to the usual standard dialysate, which has about 36.4 degrees centigrade. And they saw the primary outcomes, which were cardiovascular deaths, primary outcomes, and the secondary outcomes were about the episodes of intradialytic hypotensions. And they noticed that there was no significant group differences between both the cooler dialysate group and a usual dialysate group. Hence, the advocation by a lot of centers or other studies which says that the cooler dialysate will have some beneficial effects needs to be studied or needs to be challenged. Now, there is another area which has a big lacuna, that is anticoagulation in patients on hemodialysis. There was a lot of review analysis or small studies conducted on the apixaban comparing the vitamin K antagonists previously, but there was no big randomized control trial happened so far to give a good answer to this question. This Exadia AFNET study conducted this randomized control trial comparing the apixaban to vitamin K antagonist, fenproquinolone, in patients on chronic dialysis. This study was done in Germany. It was multi-center, happened at 39 sites from 2017 to May 2022. It was an investigator-initiated prospective randomized open-blinded outcome assessment safety study in which the groups were given, one group were given apixaban 2.5 milligram BD or a vitamin K antagonist to target INR of range 2 to 3. The primary safety outcomes were defined by first event of major bleeding, clinically relevant non-major bleeding or all-cause death. And the primary efficacy outcome was a composite of ischemic stroke, prevention of stroke, all-cause death, myocardial infarction or deep vein thrombosis, and or a pulmonary embolism. There were 97 patients randomized based on the inclusion criteria, 48 to apixaban and 49 to vitamin K antagonist, with a median follow-up of about 429 days and 506 days respectively. The adherence to apixaban was more than 80%, and the median time in therapeutic range on vitamin K antagonist was 50.7%. The composite primary safety outcome events occurred in 22 patients on apixaban and 25 patients on vitamin K antagonist. Composite primary efficacy outcome events occurred in 10 patients on apixaban and 15 patients on vitamin K antagonist. There were no significant differences regarding individual outcomes, that's all-cause mortality, major bleedings, and myocardial infarctions. So there was no difference were observed in safety or efficacy outcomes even on oral anticoagulation. Patients with atrial fibrillation and hemodialysis remain at high risk of CV events. So a larger RCTs are still needed to determine optimal anticoagulation regimens for patients with atrial fibrillation and hemodialysis. Last but not the least, we also had a publication of peritonitis guidelines. The previous guidelines were in 2016. There were no major changes, but I would still we know that with the advent of therapeutic and technical advancement, the patients on peritoneal dialysis are having a less technique failure, but peritonitis still remains major reasons for transferring to hemodialysis or death or discontinuation of peritoneal dialysis. ISPD has come up in this guideline, has given is divided into various parts like definitions, outcomes, prevention, and treatment. The definition majorly had remained the same as compared to the previous guidelines. They defined it peritonitis episode as 2 out of the 3 episodes, like having a 2 out of 3 criteria: abdominal pain or cloudy effluent with a WBC count of more than 100 with 50% of polymorphs, and a positive effluent culture. In the absence of point 3, it will be labeled as culture negative peritonitis. The definitions were divided into culture positive, culture negative, catheter related, and the time specific peritonitis, like pre-PD, which is after the catheter insertion till the day 30, and PD related, that is, and PD catheter insertion related. The outcomes were either refractory, recurrent, relapsing, repeat. This had remained the same compared to the previous guideline. Coming to prevention, they recommend that antibiotic use before the catheter placement should be given, like any vancomycin, cefazolin, had prevented the first episode of catheter-related peritonitis. The topical use of insecticide care has to be advocated. The prophylactic antibiotic after a wet contamination is recommended. Wet and dry contamination, wet like any leak or contaminated dialysate fluid infused will be are regarded as a wet contamination. They also recommend an antibiotic prophylaxis prior to any colonoscopy or any invasive gynecological procedures and drainage of PD fluid at the time of any procedures like colonoscopy or gynecological procedures. PD fluid needs to be drained at the time of procedures. Pets are not allowed in the PD exchange room, and the patients are informed to avoid hypokalemia and H2 blockers for prevention of peritonitis. It is in many studies have reported that with the use of H2 blocker there was a high incidence of gram-negative peritonitis especially. However, it was not with the PPI use. Coming to treatment, the intraperitoneal antibiotic is the preferred route definitely, and should be started as early as 6 hours with the diagnosis of peritonitis. Gram-negative and positive coverage should be the empirical regimen, and antifungal coverage should be done with every peritonitis with antibiotic use. Adjust the antibiotic to culture results whenever they are available. In refractory peritonitis, which is defined as there is no response within 5 days after starting the antibiotics, they recommended to remove the catheter or observe if the WBC count is decreasing. The organism-specific recommendations are given, which this slide summarizes the organism-specific peritonitis guidelines, which says that a gram positive, the intraperitoneal cephalosporins or vancomycin for 2 weeks to be started in patients with positive culture showing staphylococcus, treated and should be treated with 3 weeks. The various organisms are given. It's the patient organisms who are difficult to treat or having the risk of sepsis are usually treated with longer durations and with a higher antibiotics. So we won't go into the details of each and every organisms. Otherwise, there was no significant change in the latest ISPD guidelines compared to the previous ISPD guidelines. So this was all.
Those in that trial where CKD patients were included, and did this molecule have any effect on potassium? Because it is, you have mentioned only resistant hypertension.
Yes.
Whether these patients had underlying CKD, that has not been mentioned in the trial. So whether CKD patients were included in the trial. So as far as we treat, we come across resistant hypertension basically in patients who have some kind of kidney disease.
Yes, so they had included stable CKD to stage 3, but the advanced CKD patients who had other comorbidities like cardiovascular comorbidities were not included, and there was no significant hyperkalemia with androgen antibodies.
One general question: how many of us are using RAS inhibitors for treatment of hypertension in our cities? Like, I had a trial on this Findinol, where using ACE inhibitors or ARB was mandatory to be included them in the trial. I could hardly find any patients who were on appropriate dose of RAS inhibitors. I could not enroll any patient.
That's what's happening. Lot of our patients are
so much about
advanced CKD, and
but
we tend to remove
using
the.
it, I think in our CKD patients we are not using it.
True, this is true.
When he said that after the RAS was, RAS inhibitor was taken off, from the advanced kidney patients.
Yeah, that trial.
It remained because it was already advanced, I think.
Just general.
There was no further deterioration because already it was already advanced, no, below 30, below. Isn't it?
Regarding
RAS
the-
inhibitors did not made any change. That was the
Stopping RAS inhibitors did not make
Did
it.
not
did
make
not
any
make
change.
any. So you can still
In
continue
advanced, in
in
advanced.
even in advance.
Yeah.
Yes.
So we are not giving anyway for the kidneys. We are giving it for the other organs.
So earlier even our practice was not to use ARBs too much, but now up to stage 3 or stage 4. Now,
Yes, we can.
yeah, and with the availability of glyphosins, the use of ARBs now we have increased along with glyphosins. So we are finding less.
Even if we talk about findrinol,
Yeah,
the use of ACE-ARBs must for that drug to be given.
yes.
Unless because the trial has been done only in those patients
Maximum.
wherein the patients were already on ACE or ARB.
And that to optimum
It is-
dose of
It does not say that you use findrinol in patients who are not on ACE.
Yes, yes.
So maybe the earlier the thought was like the ARB decreases the progression of CKD in almost all the patients. So that's why they are including almost all the trials. They used to include that the patient should be on the adequate dose of ARB, almost all the trials. So now with this trial which convert with that ARB has no role in decreasing the progression of CKD. So like in future they may not include now. Like the use of ARB
No.
before starting the trial.
No. What, sorry, your.
Like ARB they have used in almost all the CKD trials, they used to give that ARB should be used and that should be in the optimal dose. And the use of ARB was because that it decreases the progression and that was the factor which used to be considered. Now with this trial where they have shown that ARB does not help even after stopping the ARB. The CKD
No, that is only for the advanced CKD.
Advanced disease, sir.
But it is the negative. No, you are not understood
No,
properly. You have to continue ACE inhibitors actually for the cardiovascular benefits.
Stopping ACE-ARB doesn't make any difference. That is
Yeah,
the
that means we have to continue ACE-ARBs even if the patients have advanced CKD. Okay, that means
that is the outcome of
That
the
is the
trial.
outcome of
You
that trial.
can stopping ACE-ARB does not do anything. You continue it.
you have to continue. Like we start with even a patient is on stage 1 or 2 and moderate CKDs also, but we tend to remove them when the patient goes to advanced CKD. So that the trial is saying there is no harm. There is no harm. You have to continue.
But continuing did not
So-
invite more dialysis.
Yeah.
Just a question regarding stop ACE trial. So my understanding is that the patient were already on ACE inhibitor ARB when EGFR fall below 30. Did they try to start in a patient initiate when EGFR fall below 30 for say proteinuria or cardiovascular benefit? And I just want opinion of audience. So do you think starting say EGFR up to 25 or 30? Do you think starting ACE inhibitor ARB for cardiovascular benefit will be appropriate or it should not be started?
I mean, a nice question, but the trial had included patients who were already on optimum doses of ACE-ARBs and they had an eGFR of up to 20.
30, I think.
I don't think there is any contraindication of using ACE inhibitors or ARB even in patients who have eGFR of less than 30, only if their potassium is normal. And you can monitor their creatinine and potassium during follow-up.
The major challenge we actually face in day-to-day practice is patient follow-up. So there is a biggest hindrance in either initiating or continuing.
Potassium normal hai, you can safely start. There is no harm.
I think another thing is if there is no decline in GFR more than, I mean less than,
30%.
no, not 30, 30% is too much. I follow, I mean 5 to 10% decline, then I stop.
Recommendation is 30%.
You stop.
Recommendation is 30%. Individually we may do anything.
But So you wait for 30%.
नहीं, थोड़ा सा क्रिएटिनिन बढ़ा, पोटेशियम नॉर्मल, तो we can continue. बट जितना अपन बोलते हैं एस्क्रिप्टेड ARB उतना हम लोग यूज नहीं करते हैं. Let us accept that this fact that we talk so much about using ACE ARB in our practice, but when it comes to using it, we don't use it that often, and to that those extent.
Thank you, Dr. Faizan. I think you have opened a Pandora's box. I will now welcome Dr. Vishal, who has been promoting this event ever since its inception, the last year in nephrology. And it is apt that he concludes this session, and he will be speaking about the developments in the field of acute kidney injury.
Real quick, I think we are running behind the schedule. I'll be covering this topic under following heads: acute kidney injury, fluids, and whatever newer drugs which have come up for practice in nephrology. Before I proceed, I would like to thank all the creators of the visual abstract whose slides I have used in this presentation. We all know that patients who have suffered AKI in the past eventually land up with some or the other kidney injury, and we never sign them off from our OPDs. We always ask them to keep on repeating their kidney functions. But have you ever thought about what happens to the neurocognitive impairment in patients who have suffered AKI? So the investigators from Canada tried to evaluate it, and they evaluated the AKI survivors, mostly who have underwent cardiac surgery. And they evaluated those patients under two assessments. One is a clinical assessment, which is a RBANS score, and another is a robotic assessment, which is called as KINAM. KINAM is basically a virtual reality like platform. It is for stroke patients rehabilitation. So a patient is seated in this setup, and he has to do simple tasks like joining two balls, pushing, pulling, drawing something. And the points assessed were sensory, motor, and cognitive performance. So the investigators evaluated those AKI patients, and they were followed up for 6 months, and their assessment was done after 6 months. And all the stages of AKI patients were included in this trial. And their survivors were assessed for those two heads. One is the clinical one and the robotic arm. So the score in the clinical score was 5% in AKI survivors, while those who didn't have AKI was 0%. And surprisingly, there was a lot of neurocognitive impairment in the form of visuomotor, that is 48%, and attention span loss in 50% cases, and executive task impairment in 52% cases, as compared to those who didn't have any AKI, had hardly any impairment. So yes, the patients who had AKI do suffer with some neurocognitive impairment, and they should be followed up for that. We keep on getting consults for contrast nephropathy in our day-to-day practice. Our colleague consultants from from cardiology and medicine keep on asking what should we do for a prevention of contrast nephropathy. Everything has been tried, from statins, phenyldopamin, dopamine, N-acetylcysteine, to fluids to bicarbonate. The first hard evidence to say about was ACT trial in 2011, which said that N-acetylcysteine hardly provides any benefit from contrast-associated AKI. Poseidon trial, I remember this during my residency years. It at least said that the fluid, in a graded manner, in a sliding scale manner, guided by the LVEDP, left ventricular end diastolic pressure, prevented contrast-associated AKI. But the PRESERVE trial in 2007 NEGM said that neither sodium bicarbonate and nor N-acetylcysteine was beneficial. So the investigators of the PRESERVE trial did a secondary analysis of the PRESERVE trial, and around 4,700 adults in CKD stage 4 who underwent angiography were evaluated, and they were given fluids, either 1.26% bicarb and versus normal saline. And the primary outcomes assessed were death, need for dialysis, and persistent kidney impairment at 90 days. So they divided the patients into 4 quartiles according to the volume of fluid to be transfused: 700 ml in quartile 1, quartile 2 964, quartile 3 1140, and quartile 4 1478. And they compared quartile 1 with quartile 4, quartile 2 with quartile 4, and quartile 3 with quartile 4. And they didn't find any significant interaction between duration of fluid administration, be it a rapid instillation or a slow instillation of fluid, or even the volume of the fluid which was transfused. So the conclusion here was administration of 1 liter of intravenous fluid over shorter duration of period was associated with similar outcome as compared to higher volumes, and smaller volumes less than 964 ml was associated with higher primary outcome, that is kidney injury. Next question comes the gray zone in nephrology. When to initiate what is the optimal time for initiating renal replacement therapy in AKI? So ELAN trial in 2016 leaned heavily on early initiation of renal replacement therapy, while multiple other trials which came further on showed no difference. AKI trial, Ideal ICU trial, and START AKI trial. They showed no benefit of early initiation versus delayed initiation. Early initiation meant oliguria of less than 8 hours and a lower BUN, and delayed initiation was oliguria for more than 72 hours and BUN of 112. So this was a follow-up of this was a trial which tried to AKK2 trial which tried to evaluate is further delaying of renal replacement therapy initiation did confer any benefit in the form of RRT free days. So this was a trial done in 79 ICUs in France, and it was an open label randomized trial. And inclusion criteria was AKI KDIGO guideline stage 3 patients with oliguria of more than 72 hours and BUN more than 112. So those were delayed as per the previous trials, and they tried to compare it to patients who were further delayed in initiation, that is more than 72 hours, or until they met up with the compelling indications of initiating dialysis like hyperkalemia, fluid overload, or refractory hyperkalemia, or severe metabolic acidosis. So the primary outcome evaluated over here was the number of RRT free days, and they didn't find any significant difference. 12 days in the delayed one and 10 days in the further delayed one. And the secondary outcomes of death, mortality at day 60 and hazard ratio of death at day 60 was also similar. So the AKI related complications were also similar. So the investigator concluded that in severe AKI patients with oliguria of more than 72 hours or BUN more than 112 and no severe complication, that would mandate immediate renal replacement therapy. Further delaying of renal replacement therapy did not confer any additional advantage. Kapil nicely presented about the role of balanced salt solution in transplant setup, but does that replicates into critical ill patients? That balanced salt solution are beneficial as compared to the readily available normal saline. So the previous trials evaluating this question, split trial, salted trial, and basic trial showed no difference. Both were performing equally, except for SMART trial in 2018, which showed that balanced salt solutions are somewhat better in the patient's primary outcome of kidney injury and mortality. So, PLUS trial in 2022 published in NEGM tried to evaluate a similar question of balanced multi-electrolyte solution versus saline in critical ill patients. Around 5,000 patients were randomized in double-blind controlled trial, and equal numbers were allotted in each of group. So, death from any cause at day 90, newly initiated renal replacement therapy, and mean maximum increase in serum creatinine was more or less similar in both the groups. So, they didn't find any significant difference. So the investigators concluded that the use of balanced microelectrolyte solution in critically ill adult patients did not result in a lower risk of any death or prevention of acute kidney injury as compared to vis-a-vis saline. Next question, what comes to our mind while having critical care nephrology practice is what is the optimal fluid volume, what should we give? should we be restrictive or should we be liberal in managing patients in septic shock? 2011 paper in chest by Boyd said that a liberal fluid would lead to a patient with Michelin-Man, and he would have complications like passive renal congestion and more severe AKI, requirement of renal replacement therapy, increased ventilatory days, and increased mortality. So I added those two patients into a restrictive fluid group and a liberal standard fluid group. So restricted fluid group patient on an average received around 1700 ml of fluids, while the standard group received almost twice the amount of fluids. So they tried to evaluate the outcomes. The primary outcome here was mortality, and the secondary outcomes were serious adverse effects, severe AKI, and the number of days alive. So the mortality in both the groups, the restrictive group versus the standard care, was more or less the same. Even the serious adverse effects were almost the same. In severe AKI, there was no difference, and days alive were also more or less same. So authors concluded, the investigator concluded that among adult patients with septic shock in ICU, IV fluid restriction did not result in fewer deaths at 90 days than gastrointestinal tract, and leads to increase in serum bicarbonate, and it is available as an oral drug. The data about it was presented in Valor CKD trial, which was a phase 3 study, and the recently concluded AS in Kidney Week. It showed that it slowed down the progression of CKD with correction of metabolic acidosis. The details about it are not available yet. Probably it will be published shortly. Another drug is fesomycin. It is a target. It targets a region of factor 11 mRNA to selectively inhibit factor 11. So it decreases the level of factor 11, and it is given as a subcut once a month dose as 40, 80, and 120 milligram. So the data about it in CKD patients was published in, was presented in ASN Kidney Week. It was a phase 2 study. What the authors found out, there was a dose-dependent and sustained reduction of factor 11, which actually helped in CKD patients in the form of reduced thrombosis of the AV fistulas, circuit clotting, without increased risk of bleeding. So much so that even around 19% of the group underwent cardiac surgeries and GI surgeries with the administration. And even they helped in decreasing the need of intradialytic heparin. Next one is isuzinaxib. It is a pan-NOx inhibitor. I've been hearing about this molecule, NADPH oxidase as a pathway in pathogenesis of DKD, and it inhibits the microalbuminuria in the DKD patients. It is given as a 400 milligram once a daily dose. Again, it was presented in ASN Kidney Week. The authors found that it helped in 36% reduction in urine albumin creatinine ratio at 12 weeks as compared to the placebo. Exciting one, what I feel, is tebipenem. It is orally bioavailable carbapenem with activity against uropathogenic Enterobacter C, ESBL producing, and fluoroquinolone resistant strains. It is given as 600 milligram thrice a day dosing, and it was also presented in ASN Kidney Week. It was presented in NEGM, NEGM in April 2022 as a phase 3 study. And the investigators found that it is equivalent to ertapenem with similar effects of treatment in complicated UTI and pyelonephritis and similar tolerability. There are a few exciting upcoming pharmacotherapy for glomerular diseases. One is intensified B-cell depletional therapy for lupus nephritis. This has been devised with the thought that we do away with the maintenance therapy, what is required in lupus nephritis. So they give intensified B-cell depletion in the form of weekly rituximab, followed by once a month for next 2 months. Additionally, cyclophosphamide and steroids pulses, followed by taper. I am not very sure of what exactly would be the infection risk and other complications. The authors would shortly publish it. Another molecule is sibeprenlimab, which is a monoclonal antibody against APRIL, and it is found to be useful in IgA nephropathy. And last one is cemdisiran, which is a which inhibits the hepatic generation of C5, which is the crux of the complement system, and it is again found to be beneficial in IgA nephropathy. Faizan discussed about ISPT guidelines, the prevention of PD peritonitis. The latest one gadget which has come, which is in pipeline, probably would be in coming few years would be applied in our clinical practices, Cloud Cap Connect system. It was devised by Dr. Charto and Ellie. And if you can appreciate, there's a device there which is connected to Wi-Fi, and it can be plugged into your usual electricity ports. And the basic principle, what we tell about our patients for detection of peritonitis is look for any turbidity, look for any cloudy effluent. Most of our patients won't be able to appreciate because of visual impairment, old age, or even they won't be able to appreciate what exactly is turbidity. So this cloud cap system actually picks up the effluent, the peritoneal spendylizate, and it picks up the turbidity early, and it gives around a lead time of 4 to 5 days, so that before the symptom manifests, before the patient starts having peritonitis sign, the patient can be initiated on intraperitoneal antibiotics. I'll just play this video.
The way into the indicated marking to avoid any leakages. Inspect the cuvette and identify the presence of this notch. This notch has to face the outside of the device as displayed when connecting your drain set extension. When inserting the cuvette, make sure it stays upright, avoiding any excessive friction with the inside of the device. Make sure to loop down the tube and tuck it into the groove positioned at the side of the device right next to the stand. This is the drain end that extends all the way to your drainage receptacle.
So basically the spendylizate from the CCPD cycler is connected daily with this connection which passes through this cloud cap system, and it picks up the turbidity real time, sends an intimation to the nephrologist and even to the patient. So that's our app. All four of us, Anand, Kapil, Faizan, and we tried to compile the data from last year's path-breaking trials advances to bring forth to you. I thank all of them. They actually, I kept on nagging them, and they took out time from their busy schedule to make this happen. Thank you. And I would like to thank Amit sir and Piyush sir for actually agreeing for this change in this presentation.
Thank you, Dr. Visha. It was a very crisp presentation, and we have had a very good evening of learning today. One thing that I could learn from your presentation was that why LN trial is leaning on one side and why the others are on the other side. There is one message there that the LN trial has been a single center study where it has more surgical or cardiovascular patients. So maybe these are the subset of patients where we want some early initiation of dialysis, and complex septic patients we can weigh the balance clinically. So again, the same message there. I think thank you all of you, and I will congratulate all our speakers, Dr. Anand, Dr. Faizan, Dr. Kapil. Very nice presentations and good information to all of us. And we look forward to this event next year also. Thank you.
Thank you all. I would now request our chairpersons to felicitate our speakers. Dr. Anand Chelapu. Dr. Faizan. Dr. Vishal. I would now request Dr. Monali Madam to felicitate our chairpersons. Respected chairpersons and all the delegates. I would give also thanks to JP Chemical team. And I would now request all of them to join us for the dinner.